Okay, moving on to disorders of pigmentation and melanocytes. Before you can understand these disorders, you've got to understand the melanocytes. So let's briefly review. The melanocytes are responsible for skin pigmentation. Recall that they take tyrosine, which is a precursor molecule, and then they use that to make melanin, and they make melanin within organelles called melanosomes. And that's important for board exams. They like you to know that the melanin is made in the melanosomes. Now the melanosomes are then passed off to the keratinocytes, and when they're handed to the keratinocytes, that then results in skin pigmentation. So let's go back and review briefly. This is your epidermis, this is your dermis. Of course, you've got these basal cells, and then on top of these basal cells, you've got additional keratinocytes. And within the basal cells, just at the level of the basal cells, you've got additional cells in here, which are melanocytes. Now the melanocytes take tyrosine, they make melanin, again within the melanosomes, and then they pass the melanosomes to the keratinocytes, and the keratinocytes then take up that melanin and become pigmented. So that's the basic understanding of the melanocytes. Again, they're responsible for skin pigmentation, they're present in the basal layer of the epidermis, and they synthesize melanin in melanosomes, again from tyrosine. Now one other important high-yield point, and that is that the melanocytes are derived from the neural crest, and board examiners like you to know that as well. Now the first disorder is vitiligo, and this is when you get autoimmune destruction of the melanocytes, which results in a localized loss of skin pigmentation. So the idea here is that if this is the epidermal-dermal junction, and you've got these basal cells here in the epidermis, and of course the melanocytes are here, here, and here, imagine if you knock out these melanocytes focally in a localized region, then this area of the skin, for example, would become depigmented, and that's called vitiligo. Here's a clinical image of vitiligo. Notice that this patient has normal pigmentation here, but has depigmentation here, and again, that is due to autoimmune destruction of the melanocytes. Very high yield. Board examiners want you to know that there is autoimmune destruction of the melanocytes that is localized. Now, in addition, because this is an autoimmune disease, it can be associated with other autoimmune diseases, but that's nothing that we have to memorize. That's a general principle. And then finally, the point I'd like to make is that in a dark-skinned individual, you'll clearly see that the skin becomes depigmented. However, in a lighter-skinned individual, the only way that you might pick this up, especially on a board exam, is when the patient goes to tan, or when the patient's out in the sun, certain areas of the skin will not become dark. And that's because they don't have melanocytes, and that would be a sign that there's autoimmune destruction of the melanocytes. So fail to tan certain areas of the skin. Albinism is a congenital defect where the patients lack pigmentation. It is due to an enzyme defect, usually tyrosinase, that then impairs melanin production. Now again, the idea is that if you don't have tyrosinase, you can't take tyrosine and make melanin. And so you do need to know this for the examinations as well. Now it can involve only the eyes, which is called an ocular form, or it can involve both the eyes and the skin, which is called the oculocutaneous form. And of course, when it involves the skin, it'll diffusely involve the entire skin. And there's going to be an increased risk for skin cancer. Of course, if you don't have melanin, you can't protect against UVB sunlight. So there'll be an increased risk in formation of pyrimidine dimers in the DNA. Now again, what would be the three cancers that you would get? Number 1, basal cell carcinoma. Number 2, squamous cell carcinoma. And number 3, melanoma, which we're going to talk about in a few minutes. A freckle is a small tan-brown macule. It darkens when exposed to sunlight, and board examiners want you to know why is a freckle a little darker than the rest of the skin, and that's because it has increased numbers of melanosomes. Very high yield for the purposes of board exams. There is an increased number of melanosomes in a freckle. There are no increased melanocytes, only increased melanosomes. Melasma is a mask-like hyperpigmentation of the cheeks that's classically associated with pregnancy and oral contraceptives. The next disorder is a nevus, and this is a neoplasm of melanocytes, but it's benign. Now we classically call this a mole. Now nevus can be congenital, which is usually present at birth, and one of the features of a congenital nevus is that you often see hair growing from it. So for example, here's a picture of a congenital nevus that was present at birth, and you can see there's these little strands of hair growing from it, and so when you see hair growing from it, that tells you that it's a nevus because a melanoma would not have hair growing from it. Just think about the fact that melanoma is a malignant proliferation of melanocytes, and a malignant proliferation of melanocytes is simply going to destroy skin. It's not going to skip around the hair follicles and leave the hair follicles in place. it would grow through the skin and would destroy the hair follicles along with the rest of the skin. And so the fact that you see hair coming from this lesion means that the cells are sort of respecting the hair follicles and growing around the hair follicles, and that would be a sign that you have a nevus, or a benign proliferation of melanocytes. Now, of course, this is a congenital nevus, but you can also get acquired nevi, and those arise later in life. And so these are the moles that we develop over time as we age. When you have a nevus arise later in life, what you need to know is that here is the epidermal-dermal junction, and this is where the melanocytes would be present. And when these melanocytes grow to produce the mole, the first thing that they're going to do is they're going to grow along the dermal-epidermal junction. And so when they grow along the dermal-epidermal junction, that is called a junctional nevus. Now, a junctional nevus is actually the most common mole in children. And so you can think about it, if it's going to start out this way, and it starts a little later in life, then it'll happen in children. And when it happens in children, that would be the most common mole in children. Eventually, these cells will then extend down into the dermis as well. And when they extend down into the dermis, that's called a compound nevus. Finally, this junctional component will actually disappear. And when the junctional component disappears, the only thing that will be left will be the dermal component, and we call that a intradermal nevus. Now, the intradermal nevus is the most common mole in adults, and that's because that's the very last stage. And so if it starts in a child as a junctional nevus, it'll end up in an adult as an intradermal nevus. And so adults classically develop intradermal nevi. Now, you can get dysplasia within a mole, and that could be a precursor to melanoma. Melanoma is a malignant neoplasm of melanocytes. It's the most common cause of death from skin cancer. Now remember that your key skin cancers are basal cell carcinoma, squamous cell carcinoma, and melanoma. And of course, basal cell carcinoma and squamous cell carcinoma have an excellent prognosis, and so your most common cause of death from skin cancer will be melanoma. The risk factors are all based on exposure to UVB-induced DNA damage. So the more you see sun, the more you're going to see UVB light. If you have albinism, you won't be protected against UVB light. And if you have xeroderma pigmentosum, you won't have the enzymes necessary to repair the DNA damage that occurs due to UVB light. An additional risk factor is called dysplastic nevus syndrome. This is an autosomal dominant disorder where the patients get dysplastic nevi, and of course dysplasia is a precursor to cancer, and so this can progress to melanoma. Now, when you have a melanoma, remember that it's going to be a mole-like growth, and so we need to distinguish melanoma from mole. And the way by which we do that is to look at the ABCDs. So, for example, if it's asymmetric, then we think more of melanoma. If the borders are irregular, we think more about melanoma. If the color is not uniform, we think more about melanoma. And if the diameter is greater than 6 millimeters, then we'd also be more concerned about melanoma. Now, here's a classic picture of a melanoma. Let me just highlight these principles. Number one, you can see that this is asymmetric. Number two, you can see that the borders are not regular. You can see that they're jagged. Number three, you can see that the color is not uniform. Some areas are darker and some areas are lighter. And number four, if you had a ruler, you would see that the diameter is greater than 6 millimeters. But there, of course, there is no ruler here. Now, melanoma is characterized by two growth phases. It starts with radial growth that goes horizontally along the epidermis and the superficial dermis, and then eventually there can be a vertical growth phase where it begins to grow deep into the dermis. Let's just highlight this briefly. So here is the dermal-epidermal junction, again epidermis, dermis, and melanocytes, they normally live here. Now in the very early phases you get something called a radial growth where the tumor cells basically move radially, horizontally, in this way. So it can involve, for example, the epidermis and maybe the superficial parts of the dermis, and that's the initial phase called the radial growth phase. Now during this radial growth phase, there is a very low risk for metastasis. And the reason is that the key feature, very high yield, the key feature that results in an increased risk for metastasis is depth of invasion. The deeper these cells go, the more likely it is to spread to other parts of the body, and the worse the prognosis. So of course, if you have a radial phase in which the cells are growing horizontally, there wouldn't be a very high risk. However, during the vertical growth phase, the cells begin to grow down. And as the cells begin to grow down, that then increases the risk for metastasis and makes the prognosis worse. Melanoma can be divided into 4 major subtypes. The first is lentigo maligna melanoma, and the idea here is that you've got your epidermal-dermal junction, and in lentigo maligna melanoma, you get a lentiginous. Lentiginous basically means that you remain along the dermal-epidermal junction. So you get a lentiginous proliferation of melanocytes along this junction. Now, of course, if the melanocytes are only growing in this line along this junction, the prognosis is going to be very good because you're not really going deep, you're only going horizontally, i.e. there's only a radial growth phase. And so that's why I say here in the text that it has a good prognosis because of radial growth. Superficial spreading melanoma is the most common subtype. You get a dominant early radial phase, and because of that, you get a good prognosis. Again, if this is the epidermal-dermal junction, and you've got your melanocytes growing here, and they're superficial spreading, they stay in the superficial dermis and in the epidermis, then that's predominantly a radial growth phase. And so therefore, because they haven't gone down, it's going to have a good prognosis. And that's what I say here. It's a dominant early radial phase with good prognosis. And that's what we mean by superficial spreading. It doesn't go deep. The third type is called a nodular melanoma, and this has an early vertical phase. And the idea here is that if this is the epidermal-dermal junction, then the tumor cells begin to grow, and they start growing down very early. Now, when they grow down, what they do is they push the epidermis up. And as they push the epidermis up, that's going to create a bump on the skin, which is why it's called nodular melanoma, because you get this nodule on the skin. It has an early vertical phase and a poor prognosis. The last type of melanoma is called acrolentiginous melanoma. This arises on the palms and soles. That's high yield, and that's what the word acral means. And it often occurs in dark-skinned individuals. That's also very high yield. And it so happens that this type is not related to UV light exposure. And that concludes our section on disorders of pigmentation and melanocytes.